ஸ்டார்ட் பண்ணிடலாமாங்க?
ஸ்டார்ட் பண்ணிடலாம். திங்க் எல்லாரும் மறந்துட்டாங்களா என்னன்னு தெரியல.
Good evening. Today we'll be discussing about the reliability of sperm chromatin dispersion assay to evaluate sperm DNA damage in men with infertility. This was a paper published in Fertility and Sterility in September 2021 by Dr. Sandro Esteves and his team. So basically, sperm DNA fragmentation has been used to assess sperm chromatin quality in men with infertility. The adverse effects of elevated sperm DNA fragmentation levels are that it can affect natural fertility, it can affect the embryo development, the implantation, it also has an impact on the miscarriage rate and on the health of the offspring. The DNA damage occurs mainly during spermiogenesis, during the epididymal transit, and post-ejaculation due to several factors such as varicocele, unhealthy lifestyle, occupational and environmental toxic exposure, aging, and other infections. Sperms with high DFI may contribute to nuclear genomic instability during fertilization and also during embryogenesis. The objective of this study was to investigate the intra-individual agreement of sperm chromatin dispersion assay. That is, they considered only the intra-individual similarity. To assess the sperm chromatin dispersion assay results to assess the sperm DNA fragmentation in men with infertility. The materials and methods were, it was a prospective study that was conducted between February 2018 and January 2020 from consecutive infertile men seeking infertility evaluation in 2 fertility centers in Spain and in Brazil. Totally 219 men were taken for the study, and 2 measurements of DFI was done, which is analyzed by SCD test in the same andrology laboratory at least 2 weeks apart, but not longer than 3 months. And the assessment was done by the same andrology technician with at least 4 years of experience. They included men between 25 and 45 years of age who sought infertility evaluation, men with unexplained infertility, who had clinical varicocele but with borderline or normal semen analysis, who had history of failed ART, recurrent pregnancy loss, and with sperm count more than 1 million per ml, with total motility of greater than 30% and leukocyte count of less than 0.5 million per ml. They excluded men who had a history of antioxidant or fertility drug use and surgical treatment such as varicocelectomy or bariatric surgery, fever, all this less than 6 months, and men who used medicines with potential gonadotrophic effects such as antidepressants, calcium channel blockers, finasteride, and anabolic steroids. They also excluded men who are smokers and illicit drug abusers. And in case suppose if the sample was spilled, they excluded that sample from the study. Though first the semen analysis was done, specimens were collected by masturbation into sterile cups. Participants were asked to abstain from ejaculation for around 2 to 5 days before collection. They were instructed to strictly follow the abstinence period recorded in the first test when providing a specimen for the second test. That is, as we saw, 2 consecutive samples were taken, which with a gap of around 2 weeks to 3 months interval. So suppose in case when they were giving the first sample, they had an abstinence of 3 days, they follow the same abstinence of 3 days while giving the second sample. Then after liquefaction, specimens were assessed for volume, count, motility, vitality, and morphology following the WHO 2010 manual. After this, the SCD assay was done. This assay follows the principle of DNA denaturation and protein depletion. First, acid treatment was done, which denatures the fragmented DNA, following which the lysine solution removes most of the nuclear proteins. The sperms without DNA breakage, in this, the DNA loops they appear to be spreading from a central core and they produce a halo. Whereas in case if the DNA was fragmented, either there is no halo or the halo is very minimal. So here the agarose embedded sperms are exposed to denaturing solution and observed under fluorescent microscope. Here we see the sperms here with a big halo and with a medium halo. So these are sperms without DNA fragmentation or with minimal DNA fragmentation. And here we see sperms with a very small halo, without halo, and degraded sperms. So these are sperms which had their DNA fragmented. So these sperms who have with fragmentation were counted, and at least 400 sperms were assessed. The fragmentation rate, that is the DFI rate, was calculated as the SCD positive sperms, that is the sperms without halos, by the total number of sperms counted into 100. And a minimum of 400 sperms were assessed per specimen. The statistical analysis was done, and 3 categorical classes were given, into which the sperms were graded as normal, that is with DNA fragmentation less than 20%, intermediate with number of DNA fragmented sperms between 20 and 29%, and high more than 30%. So here, both the first sample and the second sample, which is given between 2 weeks and 3 months, both were compared to see if their characteristics were similar, such as the abstinence period, the sperm DNA fragmentation, the semen volume, the sperm count, the motility, the progressive motility, the vitality, and normal form. So all these were compared between ejaculate 1 and ejaculate 2, and the p-value, it was found to be non-significant. That is, all these characteristics were almost similar in both the samples. So the results, mainly it was to see if the same person performing the DNA fragmentation assay using the SCD, the same person performing the assay in a gap of more than 2 weeks and less than 3 months, suppose if they're able to give almost a similar result, how the results were. So here, suppose in case they found that when they got a normal result, that is when the DNA fragmentation was less than 20% ejaculate 1, more than 80% got the same result, that is again it was normal in the second sample. Whereas same way, suppose in case in the ejaculate 1, the DNA fragmentation was found to be high, that is more than 30% in the first sample. Again, when the person was giving a repeat sample after a few weeks, again, it was found more than 80%. They had a similar, that is they got a similar DNA fragmentation of more than 80%. But only in this intermediate range, between 20 and 29%, only 60%, they got a similar result. And here we see but on the whole, when the bar diagram was compared, more than 80% on the whole, they were able to reproduce a similar result. So from this, it was said that around 3 out of 4 patients were classified under the same DFI class. That is, once it was classified as normal, again, 3 out of 4 patients, they were again classified into normal or intermediate or high. The discrepancy rate, that is, patients who were classified under a different class because of discordant test results the second time, was similar, that is around 20% in ejaculates initially having either normal or high. That is, there was more similarity in either normal or high DFI ranges, whereas the discrepancy was more, that is 40% among patients with intermediate DNA fragmentation levels. So it was said that the reliability of sperm DNA fragmentation rates obtained using SCD assay exceeded 80%, indicating adequate repeatability. All patients with discordant SCD values crossed only one class levels. That is, even in those 20 to 40% in whom the second sample, it showed a different DNA fragmentation class, but whoever it was different, it only crossed only one class level. Although the percentage agreement was high for normal and high SCD ranges, that is more than 80%, it was only approximately 60% in the intermediate SCD category. Coming to the clinical significance of this study, The variability is mainly due to intrinsic biological factors, example like genetic factors or associated factors like environmental factors, technical factors, lifestyle changes, disease progression, or interventional therapy. For example, if a patient changes his weight or lifestyle, or the disease severity varies, or due to the increase in age, the SGF measurements may vary. If repeat tests from an individual are performed using the same assay but different laboratory protocols, again they may vary. So retesting may be indicated in patients with only intermediate SGF values, particularly those in whom interventions to improve sperm chromatin integrity are considered. Like for example, suppose in case if it is if they fall under the intermediate category and you're thinking about doing a varicocele repair or giving hormonal therapy or using a testicular sperm for ICSI, so we may consider repeating the DFI in patients who have intermediate values. But then again, there is no other study comparing the reliability of SGF testing using this particular sperm chromatin dispersion assay. So the limitations of this were the SCD is a manual assay. So the performance characteristics that is a result of the assay, they depend on laboratory specific process and also on technical proficiency. In this study, the technicians were not fully blinded. And there was no other study to compare this with, because this is the only study which compared the SCD in intra-observed variability. And the sample number was around 219. So the other commonly used method of sperm DNA fragmentation assay, that is a tunnel, the sperm chromatin as structural assay, the SCD, and the Comet Essay. Here, the tunnel assay, basically, it quantifies the enzymatic incorporation of the enzyme DUTP into the DNA breaks. And mainly the advantage of this assay, it is sensitive, reliable with minimal inter-observer variability, and can be performed even with a few sperm. But then again, it requires standardization between the laboratories. The SC assay, it is the most validated assay, and it measures the susceptibility of the sperm DNA to denaturation. The cystometric version of the acridine orange test, it uses flow cytometry. Here, it is a reliable estimate of the percentage of DNA damaged sperm, but it requires the presence of expensive instrumentation like flow cytometer and highly skilled technicians. Next, the SCD assay that we're seeing now, it is used to assess dispersion of DNA fragments after denaturation. And it uses either optical or fluorescent microscope. It is a simple test, but then again, it is more prone to inter-observed variability. And the last is the Comet assay. It is based on the electrophoretic assessment of DNA fragments of lysed DNA, and it uses fluorescent microscopy. It again can be done in very low sperm count. It is sensitive and reproducible, but it requires an experienced observer, and there is an inter-observed variability. So in this, the SCSA assay is the most valid and has the most validation and standardization. And the tunnel and the Comet are the most labor-intensive assays. And the SCD is the most simplest here because it doesn't require any expensive equipment. So to conclude, there is a substantial intra-individual agreement between paired SCD assays results to classify men with infertility into 3 SGF categories, that is normal, intermediate, and high. But then again, this was only in those 2 centers where the study was done, where all the andrology technicians, they had more than 4 years experience, and they underwent regular yearly training and all that. So among them, they found that there were the intra-individual agreement was there. That is, it was more than 80%. The reliability of SCD assay was also adequate and exceeded 80% using 2 ejaculates analyzed within a 3-month interval under similar conditions. 3 out of 4 patients will be classified the same, mainly when the first ejaculate exhibits normal or high DFI. 4 in 10 patients with intermediate SGF levels will have discordant values. Although the evidence overall supports a single SCD test for classifying infertility patients, particularly when the first test shows normal or high SGF levels, 1 in 4 men will have discordant values in paired ejaculates. So, to take home, patients with intermediate SCD levels may warrant a repeat analysis before any decision making, that is before any intervention is sought. And we should also be judicious when using SDF test results in our decision making. Thank you.
Nice, Madhu. Thank you.
Thank you, ma'am.
Expert comments, please.
Madhu excellently analyzed this article.
Oh, thank
very
you.
well analyzed.
Thank you,
and you've told all the salient points. It is this is only one such study as
Yes.
far as this one. Now, from the study, all we know is, see, there are semen analysis in general itself is got a lot of variables. Even motility in a single patient itself, there is a lot of variability from month to month, and both even in counts and motility changes are there. Now, when you go for sperm DNA fragment assays, again, these are special tests, and you require equipments, and the technician should be highly well trained, and especially when you're doing a test like this, like SCD, which is very much technician dependent. Though though it may be a simple test, whereas when you use the other tests like Assay or tunnel, which use the flow cytometric methods, of course there is a lot of machine dependency, and cost factor is there, because when you just send for an Assay test for the patient, I think they charge nearly 8,000 to 9,000 rupees, if I'm not mistaken, apart from the routine semen analysis. But they are flow cytometric methods, and they give they are more reliable because it's not technician dependent. But this study, of course, they have made use of this one. They are trying to find out the intra-individual variabilities from between two samples. Now, the problem always comes here is the infertile group which falls in the intermediate group. When you do a substitute, it's only for the when the patients are either fall into the low category or the high category, you need not do a repeat test. But those who follow in the intermediate group, they can, as you said, they can fall this way or the other way in the next test. And this is that group. Probably 1 in 4 patients probably will have a change when you want to do a repeat analysis. And as you said, when you want to do decision making like counseling or what next step you want to do for in the infertility management as far as the male partner is concerned, then probably you would like to do a repeat test. Otherwise, I think a single SDF is more than that. Is what the study is saying. Majority, more than 80%, if they fall into the low category or the high category, you can take it for granted that probably this test is reliable. Arun?
Yes, sir. The main thing we all think about DFI is its variability when we repeat every time and how frequently we need to repeat. But this study is mentioned, and I think there is no study comparing sperm chromatin dispersion SAD methods, sir. Because main advantage is what like Madhu mentioned is the instrumentation is less and it's quite cheap, which we can do compared to SCSA, where all other methods use flow cytometry. So if the SCD, the reliability of one test is good, I think SCD will be the commonest test which we can perform to avoid cost effective to the patient. And with one test, I think we can go do. Only when kinds of indication, we go for intervention like varicocele surgery, or when we decide like TISA for ICSI, then we can repeat again and just check. But the main thing is the same technician doing the same abstinence. Those are the things which are again the problems whenever we do the DNA fragmentation. Sir. That is the only thing. Still, that we have a problem with the values varying.
The problem, Arun, is we need a good technician. There is a lot of you need standardization. because
Yes,
they
sir.
make a lot of mistakes in the basic semen analysis itself. For example, motility, counts, morphology.
Yes, sir.
So this and for when you go for DNA by SDF assays, even if it is a simple one, it requires a lot of steps in preparation of the
Yes, sir.
sample. So obviously, it is very much technician dependent. But it is a cost-wise, probably for a country like India, I think it is applicable.
Yes, sir. The kits which companies are available, they promote what is based on SCDS, sir. I think the Krishko or the SAR, the kits they have, I think those are all based on the SCD, dispersion, SCD method. So that is one effective. And what they mentioned is they have to have the patients to check for 400 sperms. That is the basic one. With me just checking for 100 and 200, I think that is where the mistake lies, sir. In this test, what they have, this thing in all patients, they have minimum of the 400 sperms is what the standardized method they do.
And one more thing in the study, the same person has done it, both the samples.
Yes, sir.
It's the same technician who does the same thing. That is where the agreement is taken into consideration. It's not that the second sample was analyzed by a different technician with the same years of experience. It's the same technician who does it again.
Yes, sir. That's again important.
They have to do 400 sperms, no? That's
yes.
Yes, ma'am.
Time consuming. It is time consuming.
And is there a minimal count below which they can't do this test?
No, they have said they have taken into inclusion that is they have to have at least more than 1 million sperm.
1 million.
Yeah, 1 million. You can't do it in severe oligozoospermia. The inclusion criteria is
1 million, 30% of total motility, ma'am, and only less than 0.5 million per ml leukocytes.
In our routine practice, when you are recommending or asking for, do you ask for these tests nowadays?
DNA fragmentation, ma'am?
Yeah.
I do DFI only in specific situations. That is unexplained infertility, recurrent pregnancy loss. These are individuals probably where you are unexplained. These are individuals probably you would look at the DFI.
Yes, ma'am.
Who have near acceptable level of count and motility, but who have recurrent pregnancy loss or who don't respond to medical assisted reproduction, medical line. These are probably individuals whom you look at the DFI.
So Dr. Vijayalakshmi is asking, what is the cost?
The SCD will be cheaper, ma'am. We can somewhere it costs from 2,500 to 4,000 depending on the center. But the SCSA, which is the most standardized, which is done in like Coimbatore, they cost about 7,000, 7,500.
7 to 9, I think they charge.
7 to 9, yes, sir. Correct. 7 to 9. So SCD is somewhere between 2,500 till 4,000 or 5,000, depending on the kits which they are using.
They use and city also. Metros, they charge more.
Charge more.
Okay. You need to have that any equipment you need to have for this? Any idea?
No, ma'am. For sperm chromatin dispersion, nothing, no special instruments like flow cytometry, nothing. Ma'am.
Just an ordinary microscope, stain and heat counting, is it?
Stain and
yes, ma'am.
Fluorescent microscope.
The only thing is the preparation and this thing is tedious and it should be experienced, time consuming.
Stain, and they have to keep on counting the sperms.
Yes, ma'am. First stain, first denaturate, then lyse, and then fixing the stain at the last. Then only you'll be able to see the halo. And then once it is done, this itself will take about, I think, 2 to 3 hours. And then counting about 400 sperms. So they should be dedicated in doing the DNA fragmentation. Because otherwise, whatever the results we have, I don't think we can be able to decide on any treatment or anything.
See, the person who does the DNA fragmentation should be doing only that. He should not be doing going and doing counts, then looking at motility, and he should be doing only this. He or she.
Mangai, what are your comments? Mangai is incidentally is our lab director and one who does all this work. Mangai, can you comment? What are your comments? Because you're doing it day in, day out. Mangai, are you there?
I thought I saw her name. Yeah.
Mangai?
She's muted, ma'am.
Unmute. Mangai, can you hear me? Sorry, I think she's out. She's a person who does, as you said, we're not going to do in every patient, though we have the equipment. It's only in very specific cases, very severe, and the testicular biopsy and the patients home with recurrent pregnancy. Sometimes, it really doesn't give a particular direction. Practically speaking, it gives a the very fact that the semen analysis itself will vary from day to day, from week to week, from month to month. How much importance can we give to a DNA fragmentation seam on a particular day on that sample? That's something. I think the same thing is disputed about the semen analysis itself. So what is the forum's opinion on all this? Do you really take it that much?
Yes, ma'am. No, exactly, ma'am. The same reason being DNA fragmentation did not come in a big way. Actually, there are papers initially.
Yeah, it's just another, really being gilded. That's all.
Yes, ma'am.
Yeah, tell me.
Yes, ma'am. That's what the variability, the reliability, and what that doesn't give it. The same thing. The sperm, the semen analysis. What we blame on this current test is
day to day.
Yes, ma'am. Now, no test for semen
it is
or
highly variable.
Does not give the fertility potential of the male is not given by any test. The semen analysis
exactly.
Again, same thing. The same
it's
issue
not
of semen
given
analysis
by our
is
semen analysis or by DNA fragmentation or sperm chromosomal assay. Nothing really gives us the prognosis for a pregnancy. It may give us a fertilizing potential, that's all.
Yes, ma'am, that's
but
all.
Then whether it relates to a pregnancy rate or success in treatment, nobody knows. And practically, if you look at it, the cost is one thing. Second, there are only few patients who will, want you to go to that level and find out what exactly is wrong with their sperm. There are some people who request that. Maybe you can offer them. But again, having said that, we cannot label them with that single day's DNA fragmentation. Am I right?
Yes, ma'am.
You can only probably, you can categorize them into the whether they would probably go in for a highly specialized form of treatment for their infertility. Probably it helps in the counseling factor. That's all. That's cannot say that you cannot brand him. You cannot brand him.
You cannot brand him, and you cannot, and even if the
ma'am voice lost. Yes, actually, I was also wondering, and they used to say at one point, it just like our blood sugar fragmentation also can keep varying, but a person like Sandro Esteves has gone and studied.
Patient wants, and you go and counsel with them, not me. I would stick on you, right?
I'm in between.
Hello. Yes.
Yes, ma'am. Your audio was.
Yeah, I'm traveling. Sorry. You carry on, please.
No, it's okay, ma'am. Can you hear us?
Yeah, sure, I can hear you.
Okay. Like you said, I was also wondering, it used to be said that it is just like our blood sugar and it keeps varying every now
Exactly.
and then, and so whether should we do it at all? But a person like Sandro Estivas has gone and done this study, and he tried to see if there is it is variable, and that means they are trying to see whether we have something to look at, some kind of damage for the sperm, I thought. And apart from that, in my practice, what I observed is, means if it is severe damage, they keep testing positive for severe. But if they are here and there, they vary, and then probably we don't know what to tell them. Also, we don't get anything. But if there is a severe DNA damage, and that is not very common, also very few patients I have seen, and repeatedly they keep on testing positive as severe damage, and they don't conceive that often also, and IVF also becomes quite difficult in them. So there is probably a subset of patients who have this severe damage where this test becomes reliable. Like in their study also, if the test is very normal, it is very reproducible, and very severe also, it is very reproducible. And the patients in intermediate category, they can have the same thing, or they can differ, right? Madhu?
Yes, ma'am.
Yeah, I feel that, but one thing, look at it practically, we go on repeating it. One is the cost, and second, at the end of it, you say high DNA fragmentation, promptly they'll come with a spontaneous pregnancy even. Sometimes, I mean, just to say that it just needs one good sperm, and it just needs one good sperm. And I mean, that's the bottom line of it. Of course, as you said, in very severe cases, as a counseling measure to substantiate what you're saying, yes. But I mean, like, use it regularly, even if, see, in institutions where they do research, for them, it's okay. But where the patients are financing their own cycles and own investigations, I mean, it's little hard to convince them to do a repeat assay, even if they find it abnormal.
Semen analysis and male infertility remains an enigma.
Exactly. Even a plain analysis, they've not come to a conclusion as yet, right?
That's why the latest edition.
And we ourselves see in our practice, somebody with 120 million, fantastic motility, normal morphology, doesn't conceive. Somebody with 2 million, you're counseling ICSI, and next month they come with a pregnancy. So where are we? I really don't know. Anyway, I feel still a person who wants to know. Some of the patients are very, they want to know what is wrong, go to the ultimate, find out, do all the tests. They read up Google, and they'll come and ask you even, why don't you do this for me? So maybe, yes, if they don't mind the cost. Again, decision making based on that is dependent on what the picture is. Yeah.
Probably buy some time before they make a decision.
Yes, maybe.
If this DNA fragmentation would have been some breakthrough, means it would have been in every, at least major cities in Tamil Nadu. Because if we have robots coming up everywhere with the costliest machine, if DNA fragmentation was a breakthrough, we would have had a CSA machine in every city. Still, I think we are not sure about the reliability, and
it is. We are not sure. All the articles you read, they are not. It is only still there is a query at the end of it.
At the end of it, yeah, yes, ma'am.
There is whether we should take it up for routine practice and counsel emphatically using that is not still ratified.
Yes, ma'am. Only in a patient where we have unexplained infertility or recurrent failures of IUI, IVF, maybe it can be used as a counseling tool. And
there
maybe
also, we cannot blame the sperm alone. we can, we don't know how they exist in in a recurrent implantation failure. We don't know what the embryo genetics, even if you do a PGTA still, we don't know the other blastomeres, how they are. So what is the endometrial genetic level, expressions, so many things in that, getting so many steps to pregnancy, and sperm chromatin assay may be one of them. There may be additional ones, additional factors which we are not able to diagnose even.
Yes.
Meenakshi,
Yes,
you
what we
want to say?
counsel is what we tell. We are not sure whether this high DNA fragmentation is responsible for your unexplained infertility or your recurrent IVF. You're not sure.
We have to put
This is-
all the factors, even
Yes, all the
things
factors.
we cannot diagnose, put it across to them, say it could be any one of these or a combination of these. That's how you would picturize unexplained infertility, right?
Yes, ma'am.
Interestingly, of late, I'm not finding any unexplained infertility. Ma'am, do you, Madhu and ma'am?
Yes, ma'am. I think we have not done
able to
DNA
explain
fragmentation
almost
for a
every
long time.
infertility.
Yes, ma'am. Now mostly PCO everywhere.
Now, something is there.
Yes.
In fact, a lot of things are there. I'm not finding one single infertility also of late.
I don't know about the statistics of it, but then of course we see a lot of patients with good ovulation, young patients, good ovulation, good postmotile count and motility, and good endometrium and not conceiving. There is still quite a lot. As you say, PCO is of course it occupies the majority of the patients list. But we do still see these 3-4 IUIs. They go on trying with everything normal. DH lab is normal, and patient sits and asks you what exactly is wrong with me.
I don't know. Maybe I am finding at least one adenomyosis or one something is there.
Maybe you should do a study on that, Vani. What is the incidence of different factors? Is there a changing pattern? Take your cases maybe 5 years ago and record what is going on now, and come out with your study for the next journal club or something like that.
Arun, as Vani is saying, is talking is about the female side. Even male patients, there are a lot of them. I can't really say what is exactly going wrong with them. Identical factor.
What I'm saying is I'm able to say something is wrong with both of them all the time.
As a couple.
As a couple.
Okay. I find more often it is the male. We hardly come across absolute normozoospermias. Invariably, there is some astino, some terato, So that is, that's what I say. If we do 10 analysis, maybe one will be a normal. I'm so happy to see that word normozoospermia. I don't know if it is the experience with other people. Hello?
Yes, some voice. Even I'm finding a lot of teratospermia.
Actually, we did a study. I don't know if I've told this already. We just did a study in Coimbatore regarding the fertility issues in, the sperm profile in normal men who have fathered children as controls, and we took our infertile men samples, and we did I think Mangai did that research, the heavy metals, and we found that she did lead, chromium, and nickel and cadmium. We found that cadmium was very high, significantly higher in the semen samples of infertile men. And this cadmium, where is it coming from? It's coming from the foundry waste and from the smoke, the cigarette smoke. So this was one study. Mangai did that. So that maybe environmental stuff is working on, and going there with all the pesticides and everything, whatever. There's nothing that we can say is devoid of chemicals or pesticides.
Yes.
So maybe that's a factor.
Stress plays a major factor. Stress plays a
Yeah,
major
definitely.
factor. A
Stress
lot of
is
these IT individuals.
yes.
Phthalates coming
Yes.
in form of plastic, they
Agreed.
also been proposed. The phthalates, which they come in the consuming items with plastic cups, plastic bottles.
Yeah, with the plastic, it is the bisphenols. Mangai, are
Yes,
you
ma'am.
there? Mangai?
Her name is there.
Yeah, she is. She told me, I called her. She was online. Probably she's gone off. Anyway, the estrogen-like substances which are found in our DDT, our plastic, aluminum plastic wrappers, and also in our all-out, the things we use, mosquito repellents. All of them have this estrogen-like chemicals. And actually, I think this was one of the long back in ASRM meets, one of the meets, it was one of the star lectures, how they found that alligators in a pond were becoming, had a smaller size of the penis. So when they investigated, they found that the factory effluents were coming into the pond. So those alligators in that pond, they had a reduced smaller penis and subfertility. I mean, I don't know about fertility, but the size of the penis they went. So just all that to say that our environment is becoming really hazardous, and there's no way you can avoid. What can you avoid? Can you avoid any wrapper with food without a wrapper? No. Similarly, even if you avoid go all organic paper and everything, in the farm they are putting all the chemicals. I mean, not everything can be organic. I know, like when they had this very severe infection of the coconuts, so they used to tie the pesticide to the root, somewhere in the root. So it'll go right to the tip. The infection was at the tip of the fronds. So something like that, it goes into the tender coconut, which the woman consumes. And, it can affect the male fetus. There can be a subtle genetic alteration that could later on come in as a male infertility. So we don't know. So where are we going with all this environmental toxins is very, difficult to say.
I think in the Namakkal region, I think Arun and Madhumitha. How about these? You get these broiler chickens. They use a lot of these estrogen-like compounds.
Sir, Namakkal broiler chicken is supplied entire.
I know, but I mean, I know. I'm not saying that Namakkal people are. I'm just saying,
sir, from there,
what is the incidence of
the broiler chicken? What is there is across everywhere. Like what Madam said, it is again an environmental toxin. We don't find predominant. Is that probably I think here people only export, and here they have their own country chicken which have I don't know. They consume.
So that is also supposed to.
We also have broiler.
See, broiler and all is only one fraction of the whole thing we are getting. It's not only broiler chicken, whatever, all the vegetables. You see how the shining way green, you'll never get that green in nature. They dip in the green peas or everything has some kind of contamination or the other. So, I mean, broiler chicken is probably one small part of it.
Yes, sir. Sir, like what you asked means we don't find much of in Namakkal, but because it is across everywhere, it's been said.
It is across everywhere. It is universal. This practice of fattening the chicken is all around, everywhere. Here we have in our farm some where they come and give us the chicks, and you have to grow them to a certain age and give it back to them. It's not Namakkal based. It is, and when they inject certain things, they come and inject without our knowledge even. So you don't know what they are injecting. And even cows and all that, they used to inject Pitocin. I remember in Chennai, we had a few cows there. So the milkman will bring a syringe with an injection. That time I was in school. I didn't know what he was injecting. It was Pitocin. Then she'll immediately, he can milk it easier. So there's so much of this thing into all what we deal with, no, as food, as even our air and water, everything. So how are we going to even stop anything?
We are
Karma.
testing ourselves.
No, that's what always when I tell the patients, they come with unexplained infertility or everything, what they ask is, sir, I don't smoke, I have exercise every day. What I tell them is same thing. In 2021 or 22, just surviving itself is sufficient. You live in this world, everything will come to you.
Exactly.
It will come. That's what I counsel them, because we don't know.
We don't know.
We breathe, we eat.
And all the fish are having, fish are full of mercury. We say
Mercury,
fish is
yes,
a
ma'am.
healthy food, have it. Fish are full of mercury.
Formalin.
Formalin, no, even in the seas, the mercury is the mercury level in most of the fish are, even in the West, the mercury levels are quite high. So where are we? And of course, yes, they add formalin to keep it longer and whatnot. It's difficult. It's very difficult to control what's happening around, and that directly hits the sperm.
And very difficult to stop eating also.
Yes, exactly. Will you say don't eat fish,
Taste
or will you say
can't.
don't eat chicken? No, very difficult. Nobody's going to listen to you.
Immediately after talk also, we're going to go eat
The
that
concept they have is, if you tell avoid non-veg, at least during till your fertility, when we have unexplained infertility, I tell them to avoid non-veg. They tell fish is okay. I tell the same thing like what ma'am tell the formalin, other things they tell mercury. Fish is also even toxic. They think that fish is good, egg is good, maybe chicken, meat, other things. Red meat is unhygienic, but this thing non-veg, I think we cannot avoid from our culture and
Yeah.
No, it's
We tell
not
the
even
patients-
non-veg. Vegetables are equally bad.
Ah, yes,
Equally bad.
Right now with the
Fruits,
pesticides they use for
they're equally bad. You know, if you take grapes, one of my patients, she'll get me a box of grapes and say, doctor, this is not dipped in that thing. I believe they have cups of pesticide and they put it on a bunch of grapes before they pick it. So she'll bring something as a special favor without that thing, you know, without whatever dipping into the pesticide. So everything, apple, orange, and whatever fruits, whatever vegetables. So I don't think we can avoid by any kind of change in food habit. And our water, what all they add to detox, I mean, to purify it.
Good evening,
Nine
madam.
out of 10 of our my patients, male patients, don't smoke or don't consume alcohol. And yet, they say, என்ன டாக்டர் நான் இதெல்லாம் எந்த கெட்ட பழக்கமே இல்லை எனக்கு போய் இப்படி இருக்கு.
My friend who drinks smokes, he has 2 children, but I don't do anything. I have children. This is the common thing they think. They think smoking and alcohol is the only contributing factor. That's what they think.
How about I wanted the opinion of others. Do you see a lot of infertility among teachers and college professors nowadays?
Off late, sir.
Yeah.
Invariably, they marry very late. The women marry late. Professors, and they spend a long time in building careers, and the women 35, 36, they marry late. That's one thing I see.
Somebody said good evening.
Ma'am, I'm Dr. Vijayalakshmi, ma'am. Good evening, ma'am.
Good evening, Vijayalakshmi.
What is the limitation, madam, for halo test? Sometimes somewhere I read low density, some nucleotides, they won't stain, madam. Faint, and that image we can't see. This
Madam, you're asking about limitation, means the count you're asking, or
sir, halo test limitation, sir. Halo test, sperm chromatin dispersion.
Yes, ma'am.
It usually measures the non-damaged DNA. That means normal DNA. This one, sir.
Yes, madam.
Yeah, what is sometimes low density nucleotides, they won't stain, no, sir. How can we give that report? Sometimes false negative may come. It won't stain properly means
Ma'am, that's what. Ma'am, we are going to one thing is, the limitation what it will accept it. But what in the test, what we are doing is when there is not properly stained, we leave out those things. Stained
Okay.
or unstained was what we take into calculation when we take, because we are taking only 400.
Okay, sir.
Each sperm might be different, and the nucleotides might be different for this thing. Like out of 1,000, maybe 300, 400 nucleotides, which one does not stain properly or moderately stained, we don't take it. We
Okay,
take the
sir.
good stained one, unstained one, take the ratio. But that's why we have the number of 400. But actually, we will see at least 600, 700. We will see which of that 400 counting will be unstained and stained properly, will be taken. So what you are telling, the vision will not be taken into account.
Okay, okay, sir. And minimum count should be how much, sir, for this test?
1 million.
1 million. The total count should be 1 million.
Is it possible, sir, for 1 million, this much counting of 400, 600 to take?
Yes, ma'am. Yes, ma'am. Out of 1 million, I think we are going to see only.
Yeah, but sometimes that now proper staining and all.
No, correct, ma'am. The main thing in allo test is to be a technician has to be properly trained. The staining should be good. If the training, if they're stained properly, we will get back. We will be able to 1 million. We will be able to count 400 sperms. But the thing is, staining is what is a very important thing in
Allo test.
Allo
Yes.
test. Allo sperm.
Yes, yes, sir. Thank you, sir.
Yes, thank you.
Meenakshi? Meenakshi?
Hi, doctor. Good
Very
evening.
silent.
No, I was just eating grapes, and Dr. Kannaki said there's something in the grapes, so I'm staring at it. No, it was a very interesting talk.
I didn't mean to frighten you.
No, not at all, doc.
I'm eating
But
dough
yeah,
glass.
it's interesting. But the same lab as well, they've done other studies. I read one more from the same team, exact same team, that has actually compared diagnostic accuracies across all these techniques. And then they've almost sort of said tunnel is the way to go. I think last year, if I'm not wrong, there is a diagnostic accuracies among SCD, tunnel, and other things by the same team. And because it's so technician dependent, and tunnel, I mean, only recently, these techniques have been implemented in infertility as it is. But then tunnel has existed over 100 years now. And, I think it's a very robust technique to fall upon. But I'm not sure about DFI being as much a significant factor in infertility, but SCD. I think I already mentioned the lab technician, because tunnel assay is very machine dependent and it's more robust. Even that we see a lot of variations all over Indian labs. So SCD, I'm not sure we'll find technicians across that are able to achieve to the same expertise level.
Yeah, but the tunnel test is a direct test. Obviously, it should be good. But again, the thing is, the machines, and again, it needs staining. The technician has to be trained, because it again stains. The nucleotides has to be stained. It's a direct method. If
but the DUTP incorporation and everything, it's very machine based, right? It doesn't involve that much of an expertise, because this is one person literally sitting throughout the day and looking at the microscope, and whatever that person finds, so-called halo, they're going to mark in manually. So this is entirely a manual technique. And the same person, in fact, they've done another study of the same technician counting the same samples over a week in a blinded manner, and the results were very, very different. So I think I'm not very sure about the consistency, because it's so lab dependent.
But the thing is, out of all the methods, the SCSA is highly standardized, because they have more studies for that. Next is SCD. Tunnel is, the way I said, it is again promising and good, but standardization, again, the cost factor, so many things are there. Again, so it does not come up in a big way.
SCSA again becomes expensive,
maybe it's good.
Right?
SCSA is flow cytometric, so it obviously is expensive. Equipment is expensive.
Yes, but it is completely automated, so it's more reliable.
Yes, exactly.
Yes, the more automated it gets, everything becomes reliable that way. But patients,
human error is bypassed.
Exactly.
Sir, but what CASA again. When we see CASA, we speak about CASA. I think it's all machine-based and computerized, but I think it is never not be able to replace the manual semen analysis, because it sometimes underestimates or overestimates. I think we have a lot of variation in CASA. Again, when we compare manual and we see, what is your opinion, sir, about CASA when we are talking about machine and automated?
I still believe a good technician does a better job than a machine. But whereas these are a specialized testing, which depends on, there is some amount of manual thing which is involved in SCSA also, because there is, you have to, get all those things prepared and then feed it to the machine. So you can have errors there also by the technician. So even
so this what you said, when it avoids the counting or the check, the seeing whether halo or halo is not there, only that is what the machine is going to do. Otherwise, preparing everything is again manual.
Yeah, exactly. The initial steps are manual. Probably the machine is good at probably automation takes upper hand when you the fatigue is not there. Human fatigue is not there. Counting 400 sperms and then having multiple samples. So that is where the machine takes over.
They also talk about combined
machine
analysis, right? The same team, when they speak of the diagnostic accuracies, they say combined SCSA and SCD versus SCD alone, they have better sensitivity. It's close to, I think, 97% with combined assays. So if you're not relying on one single lab assay,
you want to pay for it, Meenakshi.
Yeah, I know. I know.
Don't worry,
I'm not suggesting anything, but then that's what they've shown. Dr. Vani, I'm not writing this.
I will write.
But we do have, like you mentioned, we do have consistently bad DFI results.
If it is very bad, they seem to be doing very bad.
Very consistently across many labs.
They are very few, but they are very bad.
Yeah, we do have consistent results with the DFI.
Yeah. Okay, thank you, everybody. Nice discussion. Anybody else wants to say anything? Chandra ma'am?
Yes. Regarding this, actually, I agree with Dr. Kannegi, because even vegetables, even this brinjal and all, they use a lot of pesticides. So even equally, vegetables are also bad, like chicken, broiler, everything.
Yes.
So as far as
even milk, for that matter.
Yeah.
There was a recent study. In fact, vegans are more fertile than vegetarians, and vegetarians are more fertile than meat eaters. I think that was an interesting one, because vegans are non-dairy as well, so they were shown to be fertility rate was higher.
Yeah, dairy seems to be bad. Even I keep reading it all the time here and there.
Yeah. It's not the dairy, madam. It's what they add to it.
Yeah.
But then we tell the patients to limit non-veg and all that, but then we eat 4 to 5 days a week. We cannot help it.
Yeah,
that's because we have a chicken farm.
But
no, okay, I eat.
I think most of us do, Dr. Madhu. You're not the only one guilty.
I know.
Rekha? Rekha, you're there? I can see Rekha. Okay. So, shall we wind up?
Yes.
Thank you.
Nice talk and nice discussion, madam.
Thank
Lot of
you, Dr.
information. Thank you, ma'am,
Thank
for including me in this great group.
You're always welcome. No problem.
Thank you, ma'am.
Thanks, Madhu. Thanks.
Thank you,
Vani.
sir.
Thanks,
Thank you, ma'am.
Arun.
Thank you.
Good discussion, Vani. Good discussion,
Madhumitha.
Thank you, madam.
Thank you, ma'am.
thank you, ma'am. Thank you, ma'am.
Thank you.
Thank you, sir. Good night, sir. Thank you.
Good
See
night.
you in another 2 weeks. Yeah.
Yes.
Yeah, good night, everybody.
Thanks all
Night,
of
ma'am.
you.
Bye, ma'am.
Bye.
Thanks.
Madam, when will we get recording, madam?
Recording, I'll send it. I'll send it. By tomorrow, we'll get it.
Okay, ma'am. Thank you.
Thank you.
Thank you, ma'am. Bye, ma'am. Good night, ma'am.
Bye, ma. Bye, bye, bye. Nice presentation.